Hi, everybody. Welcome to today's student-led journal club talk. My name is Anne-Marie Parker. I'm a research associate for the Joplin campus of KCU. And today I'm going to be introducing our speaker, student Doctor Celine Talley. So student Dr. Talley is currently an anatomy fellow at Kansas City University and is about to begin her third year of medical school. She completed her undergraduate education at the University of Rochester with a bachelor's in general biology and later received a master's in biomedical science at KCU. In her free time, she enjoys cooking, playing basketball, and video games. So with that, I will hand it over to you, student Dr. Talley.
Thank you. I just want to start off by saying thank you all for attending my presentation today, and to the MKRC Journal Club for giving me a platform to present on. Like Anne-Marie said, my name is Celine Talley, and today I'll be taking you through my project, Mapping the Saphenous Nerve from Surgical Landmarks, an anatomic guide for Adductor Canal Blocks. All right. For completeness sake, I've included a copy of my abstract. No worries, we can't read it all right now. It is the same one I sent to you guys earlier. But if you have questions, feel free to ask any questions at the end. Before we go further into my project, I would like to give you all some background. First, I'm going to go over the saphenous nerve and why it's an important nerve block target. And then I'll go over more about how the adductor canal blocks work, how they're performed, and how that information relates to my research. So the saphenous nerve is a terminal branch of the femoral nerve that continues distally through the adductor canal, just deep to the sartorius muscle, which isn't pictured here. And it descends all the way down to the medial ankle. Now, what makes the saphenous nerve an ideal target for analgesia is it provides purely sensory innervation to the medial knee down to the medial ankle. In other words, knocking out this nerve will spare motor function. And this is highly advantageous because in a post-surgery setting, this leads to important factors like decreased fall risk, more immediate ambulation, and just better overall outcomes for the patient. And this is especially true when compared to an older local anesthetic technique where the femoral nerve is targeted. The femoral nerve, which provides motor innervation to the muscles of the anterior thigh, as well as cutaneous innervations from its distal branches. This image to the right shows you the saphenous nerve cutaneous innervation. So moving into more about adductor canal blocks, also known as saphenous nerve blocks, this block introduces a local anesthetic onto the saphenous nerve to provide pain control for surgeries of the knee, medial leg, and medial foot or ankle. The block has risen in popularity within the past few decades for total knee replacements, which will be much of our focus for my research. Traditionally, this procedure is performed by an anesthesiologist with the help of an ultrasound during a preoperative or postoperative procedure. So here's a visual for the ultrasound guided technique provided by NYSORA's webpage. Figure 2, the leftmost image, shows an ultrasound probe along the distal 2/3 of the medial thigh. Figure 4, the furthest to the right, would be the ultrasound image that would be visualized. But in figure 3 or 4, you can appreciate the cross-section of the thigh and the anatomy the anesthesiologists use to locate and bathe the saphenous nerve with the anesthetic. Got too excited. All right. So just walking you through, an anesthesiologist would note this boat-like sartorius muscle here, which overlies the adductor canal, and locate the femoral artery and femoral vein, as well as the saphenous nerve. Then being careful not to introduce the anesthetic into the vessels, it would just bathe the nerve here. So what I've just described is the traditional procedure for performing an adductor canal block, which is done by an anesthesiologist. It's a separate procedure usually performed outside of the OR prior to surgeries like total knee replacements. But while this procedure is relatively efficient, it isn't always convenient, especially in a setting like total knees, where the knee is already open and the saphenous nerve can be located. That's why a 2016 study stood out when it determined that adductor canal blocks did not only have to be performed by anesthesiologists. Pepper's 2016 study, as well as many studies following, found out that an adductor canal block could be safely performed during total knee replacements through the use of surgically relevant landmarks. By using landmarks relevant to total knee replacements, like medial epicondyle of the femur, tibial tuberosity, or the adductor tubercle, orthopedic surgeons could find and target the saphenous nerve perioperatively or while the knee capsule is open. However, in reading through these surgeon-led adductor canal block studies, we discovered that descriptive data of where the saphenous nerve exists in reference to those landmarks was lacking, and that led us to determining the intent of my research project. From reading through the literature, we determined that the saphenous nerve can be consistently found when using surgically relevant landmarks. So our hypothesis became, if surgeons are able to consistently find and target the saphenous nerve using the surgically relevant adductor tubercle, then there must be a consistent, predictable measurement between the adductor tubercle and the saphenous nerve. The goal of the study became twofold. One would be provide the descriptive data mapping of the saphenous nerve from the adductor tubercle, and the second would be determine if the statistically significant predictive model could be developed. Here's just a nice image of what a knee replacement would look like. And now on to the materials and methods, my favorite part of research, mostly the methods though. In this study, we used 18 formalin embalmed cadavers from the KCU gift donor program, which led to 34 lower extremities. We chose to exclude donors with a history of knee replacements and later on donors with hip replacements as well. I thought it would be important to find the surgically relevant landmark in a way most similar to how the landmark would be seen during surgery. To do this, we resected the patella via a medial parapatellar approach, dissected the knee capsule, and located the adductor tubercle. Locating the adductor tubercle was confirmed by an additional author to increase confidence. And after confirmation, the adductor tubercle was then marked with a blue pin, which you can kind of see there. A little hard at this angle, but the arrow points right to it. Following marking the tubercle, we carefully dissected and traced the saphenous nerve through an incision running from the anterior superior iliac spine to the tibial tuberosity. The saphenous nerve was then pinned as it exited the vastoadductor membrane. We chose this location for the saphenous nerve because it's an identifiable structure the saphenous nerve ran through repeatedly. In the images below, you can see an example of our dissections, one with the sartorius muscle overlaying the nerve and the other where the sartorius muscle is reflected. These orange arrows are just pointing out the saphenous nerve after it's exiting the vastoadductor membrane and continuing down. Following the dissection, we took pictures with a scale marker and uploaded them onto image J, where we recorded distances between the 2 points in centimeters. After completing the dissection, we also decided to disarticulate the femur, measure its length using an osteometric board. We used measurement techniques from the standards textbook and also removed excess soft tissue to reveal just the bone. These measurements were done to provide a better understanding of how the distances between the adductor tubercle and the saphenous nerve varied based on height. With this, we were able to move into the analyzing portion of our data. With our recorded data, we were able to create a customized code on GNU Octave to produce this histogram and superimpose it on an anatomically accurate femur. And just a plug for GNU Octave, it's basically a free version of MATLAB. It's really helpful if you want the usability of MATLAB, but you might not have the funds or resources to pay for it. It's basically the same thing. It's very user-friendly as far as coding goes. But back to the graph, you can see here the medial epicondyle, or the medial condyle, the head of the femur, and the greater trochanter. And just so we can take a closer look. Along the x-axis, you can see the frequency in which those ranges of distances occur. And the frequencies are color-coded as indicated by the color bar map here. Along the y-axis, you can see 8 bends, which represent ranges of distances we recorded of the saphenous nerve as it exits the vastoadductor membrane to the adductor tubercle, which is indicated by this large black arrow. Because of our code, we were able to represent the approximate distance of the nerve's exits to the adductor tubercle. So the distance from this black arrow here to the first bend at 6 is about 6 centimeters. And that's just a fun way to represent data. I enjoy just colorful graphs, really. Beyond recording ranges, we also determine our average distance of the saphenous nerve from the adductor tubercle, as well as our femur length, and then divided them further into male and female categories. Overall, our average femur length was 45.86 centimeters with a standard deviation of 3.87 centimeters. And our distance from adductor tubercle to the saphenous nerve was 10.33 centimeters with a standard deviation of 2.24. When divided into male and female categories, the average male length was larger than the average female length for both femur length and the adductor tubercle to saphenous nerve exit, which, no surprises there, males tend to be taller than females on average. So part of our goal was to determine if we could produce a statistically significant predictive model. So we decided to run a linear regression analysis. Our femur length would be independent variable X, and the distance from the adductor tubercle, marked AT, to the saphenous nerve exit would be our dependent variable Y. We ran the analysis through Microsoft Excel and produced a line plot graph that you see to the right. The blue dots are the scatter plot of our found data, and the orange dots are the predicted data points that follow an equation y equals 0.475 times x minus 11.27. I do want to note visually that this is a pretty promising looking predictive model, but numbers tend to tell a more concrete story. So the significance F of this was 7.702 to the -6 power, meaning that there is a statistically significant linear regression model or scatter plot. Our R value being 0.747 means there's a strong correlation between the length of the femur and the distance between the adductor tubercle and saphenous nerve. And our R squared being 0.557 means that nearly 56% of the variance in the distance between the adductor tubercle to the saphenous nerve can be accounted for by the femur length. Please keep these values in mind as we move into our discussion right after this. I was curious to see how the linear regression differed between sexes and separated them into male and female categories as well. I would like to note that males had a higher multiple R as well as R squared, and this was compared to overall. Into the discussion, the good and the bad. So the average distance for the adductor tubercle, where the saphenous nerve exits the vasto-adductor membrane, was 10.33 centimeters with a standard deviation of 2.24 centimeters. And the average length of the femur was 45.86 centimeters with a standard deviation of 3.87. Predictably, when these averages are separated into female and male groups, the female average is smaller than the males. And this was true for both the femur length and the distance from the adductor tubercle to the saphenous nerve exit. The averages we've determined satisfy our goal of providing descriptive data mapping of the saphenous nerve from the adductor tubercle. However, this was only half of our goal, and we still needed to address our predictive model. When performing our predictive model through linear regression analysis, we found that the significance F and multiple R were promising at 7.702 to the -6 and 0.747 respectively. However, with an R squared of only 55.7, we cannot conclude that a good predictive model was found. Ideally, for an R squared value in this setting, it should be above 70% to be considered significant. It is interesting, however, that when separating our data set further into males and females, that our data changed in two different directions. In the males, we saw an increase in multiple R value and an R squared value much closer to 70% at 66%. Alternatively, when looking at females, we saw a decrease across the board for significance F, multiple R, and R squared. It does make me wonder if a larger pool might lead to a significant predictive model, or maybe is it harder to predict the distance between the adductor tubercle and saphenous nerves in females? I doubt this option, though, just based on there being less data for female lower extremities compared to males, where there were only 11 lower extremities for the females and 16 lower extremities for the males. Lastly, our mean age for females was 84 years old, and with the presence of osteodegenerative diseases may have influenced our findings. This study illustrates the average distance between the adductor tubercle and the saphenous nerve. With this information, orthopedic surgeons are equipped with more descriptive knowledge about the spatial relationship of the nerve and the surgically relevant landmark. And unfortunately, at this time, using the length of the femur to predict the distance from the surgically relevant adductor tubercle to the saphenous nerve is not a significant predictive tool. Some future directions I would like to take this project. I would love to repeat this project in order to get a larger sample size for several reasons, but three main ones. One, to increase the power of my findings, but also to perform linear regression on a larger pool. This could also be a chance to get a more representative age population for total knees, which is about 61 years in age. And then repeating the study might allow me to record the data for more female donors, where this study only had 11 lower extremities. Other future goals would include investigating the relationship of the exit of the saphenous nerve from other surgically relevant landmarks, like the medial epicondyle of the femur or the tibial tuberosity. I would also like to repeat this project collecting data from CT scans or fresh frozen donors. This would provide a more realistic tissue model and that is sometimes lost in stiffer formalin embalmed cadavers. Lastly, my goal is to publish my work and to get a manuscript out by the end of June. My dream journal to publish in would be the Journal of Arthroplasty. Before I wrap this up, I'd like to take the time to thank my co-authors and my PI, my committee members, the KCU Gift Donor Program, as well as everyone who assisted me on this project. Lastly, thank you all for listening to my presentation and to the MKRC Journal Club for allowing me to present today. Here are my references. Thank you guys, and are there any questions?
Great presentation, student Dr. Talley. Thank you so much again for talking with us about your research. As she was just saying, does anyone have any questions? Feel free to either raise your hand or type in the chat if you can't unmute. Dr. Gordon?
Thank you. Student Dr. Talley, that was amazing work, excellent presentation, very nice graphics as well. I had just a question. You already alluded to it. It was questions I had as you were going through. I had trouble telling from the slides with your dots and, on your linear model, et cetera, how many you had in your sample size. And then, so you had the blue and the orange.
Correct.
And one was predictive and the other one was actual, right?
Yes.
So was the predictive based on population data, or like what was the predictive based? I didn't know the origin of those two sets.
That's fair. So the predictive data was an equation that was developed by me putting in the data that I had already collected. So based on the data that I collected, it produced this model that would have the best fit. If there's any statisticians out here, my stats background is a little shaky, actually just shaky. So I apologize if I'm butchering anything, but that's to my knowledge what happened there.
So you had, how many did you have in your sample? Maybe, was it 6 or 8? I couldn't really tell.
In my sample total numbers, at that point, it was 27.
Oh, that's pretty good.
16 males.
Is there any standard reference data that you could use to check your data, which is a small sample, as you've already noted, with what's already known? Or is this so cutting edge that data are not available?
I wouldn't call it cutting edge, but I haven't found data that represents that. It's not something that I think is available at this point.
Okay, very good. My other question is clinical related. In terms of translating the work to clinical application, as you alluded to, in the OR or whatever, what is the relationship of imaging data, whether it be CT or otherwise, to actual? Like, have you or others done studies where you did imaging of the limb and then actually did the measurements as you did to see how accurate the imaging predicts the actual length?
So there actually are several studies out there that use CT scans or MRI scans to predict lengths. One of our professors, Dr. Withnell, who led our medical imaging course, actually brought us kind of in the beginning stages of how we could apply that knowledge and find that data.
Thank you. Good work again.
Thank you.
Dr. Allinger, you have a question?
Hi.
Hello.
Presentation. Have you presented this anywhere other than this forum yet?
I have presented this partially at AAA. I had a poster.
So you were one of the ones that went to AAA, right? And you had a poster.
Yes.
Are you planning on presenting it anywhere else?
No. No.
Okay. I was just going to make a recommendation, a couple tips on just presentation of anatomical data. It can be really dry if you're just showing statistical numbers. People usually just want to hear, was it significant? What did you find? Images, the more images you can use, the better, because anatomy is such a visual science to begin with. But I was only going to offer that suggestion if you were going to present this again, but you're not. So I did it anyway. I don't know why.
That's fair.
27 cadavers in anatomical research is not a low number. So I wouldn't even bother putting that in the limitations on your, when you start writing a manuscript. Usually, because I mean, you'll see some stuff published with like 6 or 7 cadavers and you're like, what? How did that even get published? But it does. So yeah, I mean, when you're in the 20s, you'd love to have 100, but when you're in the 20s, you're definitely good to go, especially when it comes to anatomical research. Yeah, that was it. So when you go to do your manuscript, I would encourage you again, try to be more visual,
Okay.
just numerical, because admittedly, you said a lot of numbers, but I still don't 100% know if what you found was like what you actually found, like what your main. So could you, was the saphenous nerve, and I feel like an idiot for asking if you very thoroughly explain this, but that's just kind of how it goes when you're a teacher.
That's
You
fair.
do it, so don't worry about it. Was the adductor tubercle a reliable landmark for the saphenous nerve injections?
Could you clarify? Do you
Sorry.
mean, were you
You were
able to
trying to-
find it?
You were trying basically to find out whether or not the adductor tubercle would be a good bony landmark,
Correct.
but they wouldn't have to shoot more blindly just using the boat-shaped sartorius, right?
So in the setting of an orthopedic surgeon, the angle that they're coming in is different than an anesthesiologist. The anesthesiologist in the images I showed you would be from the medial thigh versus an orthopedic surgeon would be at the distal femur with the knee kind of like facing you and injecting this way.
Gotcha. But what you found was favorable, right? That using
And they're currently used in some procedures that surgeons who have already gone ahead and started doing surgeon-led adductor canal blocks using the adductor tubercle to just, I don't want to say guess, very educatedly guess where the nerve needs to be bathed.
Okay, good. That was all I had.
Thank you. Thanks for the feedback.
Dr. Hillard?
Presentation, Celine. I really like this presentation, and I think it has a lot of clinical applicability. I just had one question, and maybe I'm misunderstanding the conclusion point. It was your third conclusion point, and the conclusion point was at this time using the length of a femur to predict the distance from the surgically relevant abductor tubercle to the saphenous nerve is not a significant predictive tool. I was thinking that conclusion point was going to read something like it could be used as a predictive tool defined within a particular error range, but maybe I'm misunderstanding that particular statement.
And that's a fair question. So I use the 70% rule. The reason I ruled it out is because the R squared value came up as 56% versus 70% being the more accepted terms as far as statistics go. However, in the setting of orthopedic surgery where they're using mallets and hammers, maybe 56% is perfectly fine. So the next step would be talking to a clinician who actually performs this, being like, hey, if 57% of the variance being related to femur length, could you still use this and find the saphenous nerve very easily? However, from the point of stats, I can't say yes.
So there's like a 56% variance versus the 70%, which you'd really need to solidify statistically and say that's closer to. Is that how you read that?
Because basically right now it's saying that the variance we see with femur length affecting the distance from the adductor tubercle to the saphenous nerve is only 56% of the time related to that height. So you'd see height changes, or that if a femur is 60 centimeters, that adductor tubercle might be 10, it might be 16. You can't predict it as well, if that makes sense. If I'm explaining that well.
So it's only predictive half the time.
Yes.
Right.
Which I almost say 56%. It sounds like a better number, but yeah, half the time.
Yeah, that almost sounds like a coin flip. So I guess that would not be predictive.
No, probably not.
Okay. Thank you. Good presentation though.
Thank you.
I have a question, and it's purely just out of curiosity, but did you choose the saphenous nerve, or is it like assigned to you? And if you chose it, like, why did you choose this topic?
Yeah, so I chose the saphenous nerve. There were two reasons. One, the first reason being I'm interested in orthopedic surgery at this point. So I was looking through a lot of different literature, seeing what's coming up in journals, what's kind of new, and how can I get into that? And then reading the literature, just finding the adductor canal blocks, the surgeon-led adductor canal blocks and saphenous nerve stuff kind of rising. So I said, hey, where's a way that I can get into this? And some of the discussions talking about having more data to look at would be helpful. So I said, that'll be cool. On the other hand, I played basketball in college, tore my ACL twice. The first time I got a femoral nerve block, didn't like it so much. Second time I was a recipient of an adductor canal block, and my time to physical therapy was much shorter with much less pain. So just anecdotally, I was really interested in what's going on here and how can I kind of contribute to that literature.
Awesome. Thank you. Any other questions, anyone? Questions, comments? If not, thank you everybody for joining us here today on this Friday evening. And thank you again, student Dr. Talley. We hope to see you again next week. Next week's presentation is another anatomy fellow, student Dr. Celine Talley will be talking to us about a cadaveric study of intercostal neurovascular bundle variation. So hope to see you again next Friday. Have a good weekend, everybody.
Thank you.